Welcome back to another deep dive. Today, we are opening a file that I think, honestly, most of us are a little bit afraid to look at too closely. We're talking about schizophrenia. And I have to admit, before I started digging into the stack of research and, the chapter you sent over, my head was just full of, well, movie stuff.
Right, the stereotypes.
The stereotypes, exactly.
Yeah.
The guy in the tinfoil hat screaming at a lamppost, or the beautiful mind genius who's seeing patterns in the stars. It always felt like this mysterious, scary character flaw.
I think that's how most people see it.
But looking at this material, this isn't a character flaw at all. This is biology. This is machinery.
It is absolute machinery, and you're so right. The stigma does a lot of heavy lifting in our culture, but when you strip all that away and you just look at the medical text, specifically the pathophysiology and the pharmacology we have on the docket today, you realize we are dealing with a catastrophic hardware failure.
Hardware failure. That's a great way to put it.
It's not just hearing voices. I mean, that's the surface level. That's the symptom everyone knows. But underneath, there is a physical shift in how the brain processes reality.
That was the first thing that really, really grabbed me, the definition in the text. It lists these symptoms, delusions, hallucinations, disorganized thinking, but then it pivots immediately to physical evidence. I think I always assumed mental illness was invisible, like it's all software, no hardware. But the text immediately starts talking about ventricular size and decreased gray matter.
And that's the smoking gun. It really is. When you look at the brain scans of patients with chronic schizophrenia, you often see that the lateral ventricles, and those are the fluid-filled cavities right in the center of the brain, are enlarged.
So they're physically bigger.
They are physically bigger. But here's the crucial detail. They aren't bigger because they grew. They're bigger because the brain tissue around them, the gray matter, the thinking part of the brain, has shrunk. It's atrophy.
The space is there because the brain itself is gone.
The brain is physically losing volume. That's what we're talking about.
That is just terrifying. It's not just a chemical imbalance, which is what I always heard. It's a structural loss.
It's both. And that, I think, brings us to the mission of this deep dive. We have to unpack this black box. We need to understand why the brain starts misfiring. But maybe more importantly for today's discussion, we need to understand the war strategy that doctors use to fight it.
A war strategy, yeah.
Because when I look at the drug lists, the side effect profiles, the monitoring protocols we're going to talk about, it feels like a war, a constant battle of risk versus benefit.
It feels like a war where the weapons are almost as dangerous as the enemy.
That is a very, very astute observation. So today we're going to navigate the why, the biology, the pathophysiology, and then we're going to spend a lot of time on the how, the pharmacotherapy. And we aren't just going to list a bunch of drug names that are hard to pronounce. We're going to look at the strategy. Why do we accept the risk of, say, diabetes to stop a hallucination? Why do we risk destroying a patient's immune system just to give them their mind back? These are a series of impossible choices.
Okay, let's start with the why then, the biological blueprint. We mentioned the structural changes, that shrinking gray matter, but the text lists a whole bunch of theories on where this actually comes from. It's not just one thing, is it?
No, not at all. The leading idea right now is a multi-hit theory. There's no single cause. Think of it as a pile of kindling waiting for a match.
Okay, so what's the kindling?
Well, genetic predisposition is the big one everyone knows. It runs in families. If your identical twin has it, your risk just skyrockets to something like 40 or 50%.
Yeah.
But genes aren't the whole story. The text also points to obstetric complications.
So that means things going wrong during pregnancy or birth.
Exactly. Oxygen deprivation at birth, a serious maternal infection like the flu during the second trimester. Even the season of birth has been studied, believe it or not. But one of those fascinating concepts mentioned is this idea of neuronal pruning.
Pruning, okay, like a bonsai tree.
That's a perfect analogy.
Yeah.
Very similar. When you're an adolescent, your brain goes through this natural process where it prunes or trims back neural connections it doesn't need. It's like cleaning up your computer's hard drive to make the whole system more efficient. It's a healthy, necessary process.
But not in this case.
The theory here is that in schizophrenia, this pruning process goes into overdrive. It gets way too aggressive.
So it cuts too much. It snips wires that were actually important.
It snips wires that were absolutely important. It disconnects things that should be connected, especially in the prefrontal cortex. So you add that on top of a genetic vulnerability, maybe some immune system abnormalities, some of those early insults during birth, and you set the stage for the structural variants we see later in life.
So the wiring is physically frayed. That's the hardware. But then we have the fuel for the wiring, the chemicals. If you ask a random person on the street what causes schizophrenia, they'll probably say one word: dopamine.
The dopamine hypothesis. It's the grandfather of schizophrenia theories, no question. It's been around since the 1950s.
But the text makes it really clear. It's not just too much dopamine. That's way too simple. It's more of a real estate issue, right? It's all about location, location, location.
Ideally, yes. You've hit on the central paradox. The brain isn't just a bucket where you pour in a chemical and it goes everywhere evenly. It has very specific highways, these neural pathways. And the text identifies two critical pathways that are malfunctioning in completely opposite directions.
Okay, walk me through that. What's the first one?
First, you have what's called the mesocotic region,
Mm-hmm.
or the mesolimbic pathway, some people call it.
Okay, mesocotic. Let's try to visualize this. What does this part of the brain do?
Think of this as the sensory integration and salience highway. It's supposed to help you figure out what's important and what's just background noise. In this region, in schizophrenia, there is hyperactivity. Too much dopamine. It's just flooded.
Okay. And when this specific highway floods with dopamine, what happens to the person?
You get the positive symptoms, hallucinations, delusions. The brain is over-interpreting signals. It's assigning immense importance to random things. A car backfiring isn't just a car backfiring, it's a secret message. The brain is creating noise where there should be silence.
Okay, so the attic is on fire. We've got too much dopamine there. We need to lower it. Simple enough. But what's happening in the other part of the brain?
At the exact same time, in the prefrontal cortex, which is the CEO of the brain, the part right behind your forehead, responsible for planning, motivation, personality, executive function, there is hypofunction.
Hypo. So too little dopamine.
Exactly, too little. The basement is freezing while the attic is on fire.
Wow. Okay, that analogy really, really lands. So in the prefrontal cortex, because the dopamine is low, that's where you get the negative symptoms and the cognitive symptoms. You can't plan, you can't feel motivation, you can't focus.
And this creates the central paradox of treatment, which we'll keep coming back to. Almost all of our traditional antipsychotic drugs are, at their core, dopamine blockers. Their primary job is to lower dopamine.
So they put out the fire in the attic.
But they might freeze the basement even further. They can make it worse. By blocking dopamine everywhere to stop the hallucinations, you might actually worsen the lack of motivation, the flat affect, and the cognitive dulling.
That is incredibly frustrating. It's like you're trying to thread a needle with a sledgehammer.
That is the history of psychiatry in a nutshell, my friend. And to complicate it even further, the text is very clear that it's not just dopamine. We have other major players in this game. Glutamate and serotonin.
I saw that. Glutamatergic dysfunction. That is a mouthful.
It is. But it's a really interesting idea. Basically, glutamate is the major excitatory neurotransmitter. It's the gas pedal of the brain. The theory is that if a specific glutamate receptor, the NMDA receptor, isn't working right, if it's underactive, it can actually mimic that dopamine hyperactivity.
How does that work?
Well, the glutamate system is supposed to act as a brake on the dopamine system. So if the brake line is cut, if there's not enough glutamate activity, the dopamine car just goes flying off the rails. So you might look at a patient and think, too much dopamine, when the root cause is actually not enough glutamate regulation.
So you could be treating the wrong chemical system entirely.
Or at least not the primary one. And then there's serotonin.
Right, serotonin or 5-HT.
Exactly. The text notes that patients with those abnormal brain scans, the ones with the enlarged ventricles, often have higher concentrations of serotonin in their blood. And this is really important because the newer drugs, second-generation antipsychotics, don't just block dopamine. They focus heavily on blocking a specific serotonin receptor, 5-HT2A.
So the chemical soup is messy. The wiring is frayed. The structure is literally shrinking.
Okay, let's pivot from the why to the what. What does this actually do to a human being? Section 2, the clinical picture.
Right. So to make sense of the symptoms, we generally group them into 3 clusters. You have the positive symptoms, the negative symptoms, and the cognitive symptoms.
And positive sounds, well, it sounds good. But in medicine, positive just means present when it shouldn't be, right?
Exactly right. Think of positive as something being added to reality. These are things that shouldn't be there, but are. The dramatic, headline-grabbing symptoms.
Okay, so the big one, hallucinations.
Yes. And auditory is by far the most common, hearing voices. And we have to be clear, these aren't just your inner thoughts or your conscience. To the patient, they sound as real and external as my voice sounds to you right now.
What do the voices say? It varies. They can be critical, insulting, you're worthless, you're stupid. They can be commanding, telling the person to do things. Or sometimes it's just a running commentary, like a sportscaster, narrating their every move. Now he's brushing his teeth. Now he's walking to the kitchen. It's incredibly distressing.
I can't even imagine. Okay, and then delusions. These are beliefs, but I feel like we use the word delusional so casually. Oh, he thinks his favorite team is going to win the championship. He's delusional. What does a real clinical delusion look like?
A clinical delusion is defined as a fixed, false belief. And fixed is the most important word in that definition. It means you cannot argue them out of it with logic or evidence.
So you can't reason with it.
You can't. If a patient has a persecutory delusion that the FBI has planted a listening device in their radiator, and you show them the radiator's unplugged and cold, they won't say, "Oh, I guess I was wrong." They'll say, "Of course. You're using the new wireless radiator technology."
So reality just rewrites itself to protect the delusion.
Precisely. And then, under the positive symptom umbrella, we also see disorganized speech. You'll sometimes hear this called word salad or loose associations.
What does that sound like?
The logical connections between ideas just completely break down. You might ask a simple question, like, "How are you feeling today?" And they might reply, "The sky is very blue because the letter 7 is hungry for Tuesday." To them, in their mind, there is some kind of symbolic or clang association there. To us, it's just chaos.
And the last one listed is ideas of influence. That one sounds particularly scary, that feeling of being controlled.
It's a terrifying loss of autonomy. It's the belief that you are not in control of your own mind or body, that your thoughts are being inserted into your head by an external force, we call that thought insertion, or that your thoughts are being broadcast out loud for everyone to hear, or even that your thoughts are being withdrawn, stolen right out of your head. You feel like a puppet.
Okay, so those are the positive symptoms, the fire in the attic. Now let's talk about the negative symptoms, the freezing basement. The text says these are things taken away from function.
And honestly, these are often harder for families to deal with in the long run than the hallucinations. Because with these, it looks like the person they love is just disappearing, fading away.
Give us the breakdown. What are the core negative symptoms?
The text lists 5 main ones. First is alogia. That's a poverty of speech. They just stop talking, or when they do, they give you these brief, one-word, empty answers.
Then there's avolition.
Avolition, a total lack of drive or motivation. They can't initiate and sustain goal-directed activities. They might sit in a chair for 8 hours straight, not because they're lazy, but because the biological spark to say, "get up and do something," simply isn't firing.
That's heartbreaking. It could look so much like profound depression or even just laziness, but it's a broken circuit.
It is a broken circuit. Then you have anhedonia. That's the inability to feel pleasure, the things they used to love, music, food, hobbies, seeing friends. It all just feels flat, like nothing.
And flat affect.
Flat affect, this is a big one. The face becomes a mask. There's very little expression of emotion. They might tell you about something terrible that happened, but their face and tone of voice are completely neutral. It doesn't mean they don't feel it inside, but they can't express it.
So alogia, avolition, anhedonia, flat affect, and social isolation is the last one.
Right, which is often a consequence of all the others. They withdraw from the world. And the text makes a really grim but important point here. These negative symptoms are generally much less responsive to our current medications.
That's the freezing basement problem again, isn't it?
It is. We have decent tools to block the dopamine, to stop the voices, to put out the fire, but we haven't found a great way to boost the drive and the pleasure in the speech without making the voices come screaming back.
So with all this going on, how does a doctor actually make the official diagnosis? I mean, if I have a really bad month where I feel unmotivated and maybe I'm a little paranoid about my boss, do I have schizophrenia?
No. The diagnostic criteria, the DSM-5, are very, very strict about this. To get the diagnosis, you need to meet what's called criterion A.
Okay, what's that?
That means you have to have 2 or more of those active symptoms for at least 1 month. And this is the key part. At least one of those symptoms must be one of the heavy hitters: delusions, hallucinations, or disorganized speech. You can't get a diagnosis based on just the negative symptoms alone.
So you need the psychosis. You need the break from reality. And what about the timeline?
The timeline is also critical. The rule is continuous signs of the disturbance must persist for at least 6 months.
6 months? Why so long?
Because it captures the whole arc of the illness. It includes the prodromal phase. That's the buildup where things start getting weird. The person might get more withdrawn. Their grades might slip. Then the active phase, the full-blown psychosis. And finally, the residual phase, the aftermath.
The residual phase. That sounds almost like a hangover from the psychosis.
That's a really good way to put it. The storm has passed. The voices might be quiet. The delusions might have faded. But the landscape is damaged. In the residual phase, the patient is often left with persistent negative symptoms. They're often anxious, suspicious, socially withdrawn. Their insight might be very poor. They might not believe they were ever sick in the first place.
Okay, so we've diagnosed it. We understand the hardware failure. Now we have to try to fix it. This brings us to Section 3, the pharmacotherapy strategy. In reading this section, it felt like a history lesson mixed with a high-stakes chemistry lab. We have the first generation and the second generation drugs.
The FGAs and the SGAs.
Of course.
Or the typicals and the atypicals. This is the great divide in the history of antipsychotic medication.
Let's start with the originals, the first generation. Drugs like haloperidol, chlorpromazine. These are the drugs from the 1950s, right? I've heard them called things like the chemical lobotomy.
That's a very harsh term, but it's not entirely unfair in some respects. These drugs were miraculous for their time. They literally emptied the asylums. They were the first things that could reliably stop the voices and the delusions.
Right.
But they were very blunt instruments. They were high-potency dopamine blockers. They just smashed the dopamine receptors everywhere in the brain.
So they absolutely put out the fire in the attic.
But they also smashed all the furniture and froze the basement solid. The risk of those severe neurological movement disorders, EPS, which we will get to in detail, was massive. People walked with what was called the Thorazine shuffle. They looked stiff, they drooled, they were sedated, they looked like zombies.
So then the 90s roll around and we get the second generation, the SGAs, risperidone, olanzapine, quetiapine, and the sales pitch was basically, hey, we fixed the zombie problem.
That was exactly the pitch. No more movement disorders. These are safer. These are better for negative symptoms. And to a certain extent, that is true. The SGAs have a much, much lower risk of making you shake or stiffen up. They work differently. They block serotonin as well as dopamine, which seems to create a softer, more targeted landing.
But there's always a but in this story, isn't there?
There is always a but. The but is metabolic. We essentially traded a neurological problem for an endocrine problem. Instead of shaking and stiffness, patients started gaining massive amounts of weight. Their cholesterol skyrocketed, their blood sugar went up, they started developing type 2 diabetes at alarming rates.
So you have to choose your poison. Do you want to have Parkinson's symptoms or do you want to have heart disease?
It is the pick your poison scenario that defines modern psychopharmacology. And this brings us to what is probably the most important, most influential study ever done in schizophrenia treatment, the CATIE study.
I saw this in the text. It was a huge government-funded trial, and it compared a bunch of the fancy new SGAs, olanzapine, quetiapine, risperidone against an old, cheap, first-generation drug called perfenazine.
That's right. And at the time, everyone expected the new drugs to just blow the old one out of the water. I mean, they cost 10, 20 times as much. They were marketed as revolutionary breakthroughs.
And the result, what happened?
The result was a bombshell. It was a shock to the entire psychiatric community. The study found no significant difference in overall efficacy between the old cheap drug and the new expensive ones.
Wait, really? None. They all worked about the same.
In terms of pure symptom control, on average, yes. The billion-dollar industry was, well, the marketing was ahead of the science, but there was a very important nuance. The study also looked at persistence, basically how long patients were willing to stay on the drug before quitting.
And there was a winner there.
There was. Olanzapine, which is the brand name Zyprexa, had a modest superiority in persistence. People stayed on it longer than the other drugs.
So why? Did it work that much better?
It worked slightly better for some people, perhaps. It's also a bit sedating, which can be helpful initially. But, and here's the giant kicker, olanzapine also had the absolute heaviest metabolic baggage. Patients on olanzapine gained the most weight and had the worst changes in their lipids and glucose.
That is such a complicated result. This drug works best at keeping people on it, but it might also kill you slowly from metabolic disease.
That is the dilemma in a nutshell. So with this messy landscape, how do we navigate it? The text outlines a treatment algorithm, a step-by-step guide.
The steps to stability. Okay, walk us through stage 1. I've just been diagnosed. What's the first move?
Stage 1. Pick a drug and give it a fair trial. Usually we start with an SGA, a second-generation agent. Based on the CATIE data and others, we try to avoid olanzapine as a first choice because of that intense weight gain. And we always avoid clozapine first because of its unique safety risks. So maybe we try aripiprazole or risperidone or ziprasidone, one drug.
Okay, let's say I'm prescribed risperidone. I take it for a few months, the voices get quieter, but they don't stop. I still can't function. It's not working well enough. What's next?
Then we go to stage 2. If the first trial fails due to inadequate response or side effects, we switch. We try a different single agent from a different class if possible. So if risperidone failed, maybe we try clozapine or lurasidone. The key is you have to give at least 2 different monotherapy agents a fair shot at an adequate dose for an adequate duration.
And if that fails too, if I've now failed 2 appropriate trials,
Then you are officially, by definition, labeled treatment resistant. And this is where the entire strategy changes. This is where we move to stage 3. And stage 3 is one word: clozapine.
clozapine. This drug seems to have this mythical, legendary status in the text. It's in a section all by itself. Why is it considered the heavy hitter?
Because it works when absolutely nothing else does. It is the only drug that has been consistently proven to have superior efficacy for treatment-resistant schizophrenia. It's also the best drug we have for reducing the risk of suicidal behavior in these patients. For many, many people, clozapine is the difference between living in a state hospital and having a job and an apartment.
It sounds like a miracle drug, so why on earth aren't we giving it to everyone on day 1? If it's so much better, why wait?
Because it has a black box warning that is absolutely terrifying. It can cause a condition called a granulocytosis.
Okay, let's break that word down. A granulocytosis.
A means no. Granulocytes are a type of white blood cell. Specifically, it wipes out your neutrophils, the frontline soldiers of your immune system that fight off bacterial infections.
So it deletes your immune system.
In about 0.8% of patients, effectively, yes. It can cause a catastrophic drop in white blood cells. If this happens, a simple sore throat or a small cut can turn into overwhelming sepsis and death within a matter of days.
0.8%. That sounds small. It's less than 1 in 100.
It sounds small until it happens to your patient or to you. And because the consequence is potentially death, the FDA mandates an incredibly strict, incredibly burdensome monitoring protocol.
How burdensome.
Imagine you are the patient.
Yeah.
You're already struggling. You might be confused, paranoid, having trouble just organizing your day to take a shower. To take this one pill, you are required to go to a laboratory and get your blood drawn every single week.
Every week. For how long?
For the first 6 months.
Yeah.
Every single week, without fail. If you miss a single blood draw, the Central Pharmacy Registry is legally not allowed to dispense your medication. The system is locked down tight.
That is a massive leash to be on. That's a huge barrier to care.
It's an enormous barrier.
Okay.
After 6 months, if your blood counts are stable, it goes to every 2 weeks. Then after another 6 months, it can go to monthly. But you are tethered to that needle for as long as you take the drug.
And there's a cutoff number, right? A point of no return.
Yes. If your white blood cell count, your WBC, drops below 2,000, or your absolute neutrophil count, the ANC, drops below 1,000, it's a red alert. You must stop the drug immediately, and you can likely never take it again.
Is that the only major risk with clozapine?
I wish. It's a very tricky drug. It also significantly lowers the seizure threshold, and this is dose dependent. The more you take, the more likely you are to have a grand mal seizure. It also causes severe orthostatic hypotension. You stand up, your blood pressure crashes to the floor, and you faint. You have to titrate the dose up incredibly slowly over weeks.
And there was one other side effect mentioned that sounded, well, weirdly specific. Ciliary.
Why, yes.
Yeah.
Excess drooling.
And we're not talking about just a little bit of spit here, are we?
No. We're talking about patients waking up with a soaking wet pillow every single morning, choking on their own saliva when they lie down, having to carry a cloth with them during the day. It sounds minor compared to immune system failure, but for quality of life, for social dignity, it's humiliating and can be a reason people stop the drug.
It just really emphasizes this theme we keep coming back to, the cost of treatment. We fix the mind, but we tax the body in so many ways. And I want to dive deep into that now. Section 5, the adverse effects deep dive. Because the text breaks down these movement disorders, the extrapyramidal symptoms, the EPS, and they sound like something out of a horror movie.
They are deeply frightening to witness and, by all accounts, even scarier to experience. Let's start with the one that happens the fastest. Dystonia.
This happens right away, right? Within days.
Very fast. Usually within the first 24 to 96 hours of starting a drug, especially a high-potency FGA like haloperidol. A dystonia is a sustained, powerful muscle contraction.
Like a muscle cramp.
Like a muscle cramp from hell that won't let go. You might get torticollis, where your neck muscles spasm and twist your head to the side and it just locks there. Or you can get an oculogyr crisis. The muscles controlling your eyeballs spasm and pull your eyes straight upward. You are literally stuck looking at the ceiling, unable to look down.
That sounds wildly panic-inducing, just the loss of control.
It is absolute panic. And the truly dangerous one is laryngeal dystonia. If the muscles in your throat and larynx lock up, your airway closes.
Right.
That is a life-threatening medical emergency.
How do you fix it? Is it permanent?
Thankfully, no. And it's actually very easy and dramatic to reverse. An intramuscular injection of an anticholinergic drug like benztropine or diphenhydramine, which is just Benadryl or a benzodiazepine, breaks the spasm within minutes. It's like a magic trick. The patient goes from being locked up and terrified to completely relaxed almost instantly.
Okay, so that's the acute attack. What happens a bit later on?
A week or two into treatment, you might start to see pseudo-Parkinsonism.
So fake Parkinson's disease.
Essentially, yes. Because we are blocking dopamine in a specific part of the brain called the nigrostriatal pathway, which is the exact pathway that degenerates in real Parkinson's disease, we're chemically inducing the symptoms of Parkinson's.
And what are those symptoms?
The patient gets a resting tremor, often a pill-rolling tremor in their hands. They get cogwheel rigidity. If you try to passively move their arm, it jerks and clicks like a ratchet. They develop the mask-like facies, a flat, expressionless face, and the shuffling gait.
And again, this is just because the drug is too blunt. It's hitting the movement center when we were only trying to hit the hallucination center.
That's the problem. But the side effect that patients themselves often describe as pure, unadulterated torture is akathisia.
Describe that for us. What did that feel like?
It's an intense, unbearable inner restlessness. It's not just being fidgety or having restless legs. Patients describe it as a sensation that their bones are on fire or that they want to crawl out of their own skin. They literally cannot sit still. They pace endlessly. They rock back and forth. They shift their weight from foot to foot.
And I have to imagine if you're already feeling paranoid or hearing voices, feeling like your skin is crawling on top of that doesn't help.
It makes everything 1,000 times worse. And akathisia is strongly linked to higher rates of suicide and noncompliance. Why would you keep taking a pill that makes you feel that way? And the tricky part is, the drugs we use for the other movement problems, the anticholinergics like benztropine, don't work very well for akathisia. We often have to use beta blockers like propranolol to try and calm it down.
And then there is the one that casts the longest shadow, the specter of permanence, tardive dyskinesia, TD.
This is the long-term cost. Tardive means late onset. This doesn't show up in the first week. This shows up after months or, more commonly, years of treatment. And it's characterized by these abnormal, involuntary hyperkinetic movements.
What kind of movements are we talking about?
Most often, they're facial and oral. You'll see lip smacking, puckering, chewing motions when there's nothing in their mouth, or the classic fly-catching tongue where the tongue darts in and out of the mouth uncontrollably. It can also affect the limbs with writhing movements or the trunk.
And the really scary part is, it doesn't always go away when you stop the drug.
No, that's the terror of it. It can be irreversible. You could stop the antipsychotic, and those movements might continue for the rest of that person's life. That's why prevention is the absolute key, using the lowest effective dose for the shortest possible time, using the SGAs, which have a lower risk than the FGAs. And if TD starts to develop, we often have to switch the patient to clozapine because clozapine has a very, very low risk of causing TD and can sometimes even suppress it.
So we have the whole spectrum of movement disorders. Now let's circle back to the other big category of harm, the metabolic syndrome, the so-called SGA curse. We mentioned weight gain, but I want to be specific. The text gives a sort of ranking, doesn't it? Which drugs are the worst offenders?
It does. There's a clear hierarchy. If you are worried about weight and metabolic health, olanzapine and clozapine are the heavyweights, pun intended. They consistently cause the most significant weight gain, the most disruption to lipids and glucose metabolism.
So they're the highest risk. Are there any skinny drugs? Any that are safer on the metabolic front?
There are. There are definitely safer bets. The text identifies ziprasidone, aripiprazole, and lurasidone as being on the other end of the spectrum. They're considered weight neutral or have a very low risk of causing these problems.
So that's the obvious question then. Why don't we just give everyone ziprasidone? If it doesn't cause weight gain, it seems like a no-brainer.
It's a great question, and the answer comes down to two things. Individual efficacy, because what works for one person might not work for another, and pharmacokinetics, which we'll get to in a minute. It has some tricky absorption issues that make it harder to use. It's always a trade-off.
The text also flags a specific heart risk, QTc prolongation. This is an electrical thing in the heart.
It is. The QT interval is a measurement on an EKG. It represents the time it takes for your heart's electrical system to recharge between beats. Some antipsychotics, unfortunately, stretch this interval out. They make it longer.
And if it stretches too far, what's the danger?
The danger is a specific life-threatening arrhythmia called torsades de pointe. It's a chaotic, twisting heart rhythm that can degenerate into ventricular fibrillation and cause sudden cardiac death.
Sudden death, just from taking a pill.
It's rare, but it is very real. An old drug called thiordazine actually has a black box warning specifically for this. Among the newer drugs, ziprasidone is the one most associated with it. It's why there's a hard and fast rule. If a patient's QTc on an EKG goes over 500 milliseconds, you have to stop the drug, period.
Okay, before we move on from the scary stuff, we have to mention the perfect storm of side effects, the one that combines everything. Neuroleptic malignant syndrome, NMS.
This is the nightmare scenario. It's the one every psychiatrist dreads seeing. It's rare, maybe 1% or less with the older drugs, but it is rapidly fatal if it's missed.
What does it look like? How would you know it's happening?
It's a very dramatic clinical picture. The patient develops extreme muscle rigidity. We call it lead pipe rigidity. You try to bend their arm, and it feels like you're trying to bend a steel bar. Their temperature spikes to a high fever, over 100.4 Fahrenheit, but often much, much higher. They get confused, delirious, their level of consciousness changes, and their autonomic nervous system goes completely haywire. Their blood pressure is all over the place, their heart is racing.
It sounds like the body is literally short-circuiting and cooking itself from the inside out.
That is a very good description. The intense muscle rigidity generates enormous heat, and the muscles start to break down, releasing proteins that clog up the kidneys. You have to stop the antipsychotic immediately. There's no negotiation. Then you start supportive care, cooling them down, and sometimes we use muscle relaxants like dantrolene to try to shut down the process. But it's an ICU-level emergency.
It's just unbelievable how dangerous these tools are, which makes knowing how to use them effectively, down to the last detail, even more critical. Which brings us to Section 6, Pharmacokinetics. This is the real user manual stuff. And there's some really weird, really specific rules here.
There are, and they are not suggestions, they are rules. And if you or the patient ignores them, the drugs simply will not work or they'll become toxic. Let's start with the most basic one, food.
Right. Ziprasidone and lurasidone. The text says they must be taken with a certain amount of food.
And not just a cracker or a cup of tea. It has to be a real meal. The recommendation is at least 350 calories for lurasidone and 500 calories for ziprasidone.
What happens if I don't? What if I take my ziprasidone on an empty stomach with this black coffee in the morning?
The absorption of the drug from your gut into your blood drops by 50%.
50%. So I'm only getting half the dose I was prescribed.
Exactly. Imagine a doctor prescribes 80 milligrams. The patient takes it without food. They're only actually getting 40 milligrams into their system. The psychosis comes back. The doctor thinks, well, I guess ziprasidone failed for this patient. But the drug didn't fail. Breakfast failed.
That is a massive, massive variable that's so easy to miss. And then there's acenapine, that's the sublingual one, right? Under the tongue.
Yes, it comes as a tablet that dissolves under the tongue. And for that one, the rule is no food or drink for 10 minutes after you take it.
What happens if I take a sip of water right after it dissolves?
You wash it down into your stomach where it has almost zero bioavailability. You've just wasted the dose. Again, it's these tiny behavioral details that determine success or failure.
But the most mind-blowing interaction in the entire text for me was smoking.
The CYP1A2 induction. This is a classic, and it's absolutely fascinating.
Explain this to me. We all know smoking is bad for you, but here you're saying that the act of smoking actually changes how your body processes the drug.
It does. The smoke from cigarettes, not the nicotine, but the polycyclic aromatic hydrocarbons in the tarax, as a powerful signal to the liver. It tells the liver to rev up the production of a specific metabolic enzyme, an engine called CYP1A2.
And CYP1A2 is the main engine that chews up and gets rid of these drugs.
Specifically clozapine and olanzapine. It metabolizes them very quickly. So if you are a heavy smoker, your liver is chewing up these drugs at double speed. You might need a much higher dose than a non-smoker to get the same therapeutic effect.
Okay, so the doctor knows I'm a 2-pack-a-day smoker and gives me a high dose of clozapine. It works. But then I get admitted to a psychiatric hospital, and all psychiatric hospitals are non-smoking.
Precisely. The moment you are admitted, you stop smoking cold turkey. The hydrocarbons from the smoke wash out of your system within a day or two. The signal to the liver to rev up that CYP1A2 engine disappears. The engine slows down to normal speed. but you're still taking that same high dose of the drug.
So the drug levels in my blood start to build up.
They skyrocket. You can go from being therapeutic to toxic in a matter of days. The text says that smoking increases the clearance of these drugs by as much as 50%. So quitting smoking can effectively double your blood level if the dose isn't adjusted downwards.
That is wild. A healthy choice quitting smoking can lead to a dangerous overdose.
It forces clinicians to be detectives. How many cigarettes a day do you smoke? When was your last one? Did you just quit yesterday? All these questions are critically important.
Let's touch on adherence. Because with all these rules, take it with food, don't drink water, what's your smoking status, don't forget your weekly blood test, it's so hard. So for some patients, we use long-acting injectables, the DiPiro shot.
These are absolute game changers for patients who struggle with taking pills every day. Instead of a daily battle, you get one shot every 2 weeks or every month, or with some of the newer ones, every 3 or even 6 months.
But you can't just switch someone from a pill to a shot blindly, can you?
No, absolutely not. For most of them, you have to prove that the patient can tolerate the oral version of the drug first. You don't want to inject a month's supply of medication into someone's muscle, only to find out they have a severe allergic reaction to it. You can't take it back out once it's in there.
And the conversion math seems tricky. The text mentions that risperidone consta, the injectable form of risperidone, needs a bridge of oral medication.
It does. This is a classic pitfall. Because of the way the drug is encapsulated in microspheres, it takes about 3 weeks after the first injection for it to actually start releasing steady drug levels into the blood. So for those first 3 weeks, the patient has to keep taking their oral risperidone pills every day.
What happens if they stop the pills the day they get the shot?
They'll have a 3-week gap with no medication coverage that will almost certainly relapse. But then you have a different one, paliperidone palmitate, which is different, right?
Yes, and this was a huge advance. It uses a loading dose strategy. You give a big shot on day 1, and then another big shot a week later to rapidly pump the drug levels up to a steady state. No oral overlap is needed. That's a massive advantage for a patient who is refusing to swallow any tablets.
There was one really serious specific warning about olanzapine palmitate, the long-acting injectable olanzapine, post-injection sedation delirium syndrome. That sounds bad.
This is a rare but very scary event. In about 2% of injections, it's thought that the drug accidentally gets into the bloodstream too fast. Maybe a blood vessel was nicked during the injection into the muscle.
And it hits the brain all at once, like a massive overdose. Exactly. An immediate massive overdose effect.
Yeah.
The patient can become extremely sedated, confused, delirious, or even comatose within minutes to hours.
Oh.
Because of this risk, any facility that gives this shot has to have a protocol where the patient is strictly observed for 3 hours after every single injection. They can't just get the shot and leave.
Again, the burden, the sheer logistical burden. Okay, now you have to stay here for 3 hours. It is not easy to be a patient with schizophrenia.
It is a full-time job just managing the illness and its treatment.
Let's close out the details with Section 7. A quick look at special populations, specifically pregnancy and lactation. This has to be one of the hardest conversations in all of psychiatry.
It's excruciating. You have a woman with a severe mental illness who wants to have a baby, which is a fundamental human desire. But the medications that keep her stable carry risks to that baby.
The text mentions a risk of birth defects.
A slightly increased risk, particularly with some of the older, low-potency FGAs. But the bigger risks we see are often obstetrical. A higher rate of preterm birth, low birth weight, and for the mothers on the weight-gaining drugs, a much higher risk of gestational diabetes.
And what about the baby after it's born?
The FDA has an official warning about this. Newborns who are exposed to antipsychotics in the 3rd trimester are at risk for withdrawal symptoms. They can be jittery, have muscle tremors or stiffness, they can be sleepy, or have trouble feeding.
But on the other hand, if the mother stops her medication,
she runs a very high risk of having a psychotic relapse during or after the pregnancy, which is also incredibly dangerous for her and the baby. The stress, the poor self-care, the chaos of psychosis, it is a constant agonizing risk-benefit analysis for every single patient.
And what about breastfeeding?
Most of the drugs do pass into the breast milk to some degree. But the text calls out clozapine as the big no. It's not recommended. It actually concentrates in breast milk. The text says the levels in the milk can be 279% of the levels in the mother's blood. The baby will be getting a massive dose.
Wow. Okay, one final medical oddity to wrap up the risks. Thermoregulation.
Poikilothermia. I love this word, even though the condition itself is very dangerous.
It sounds like something a reptile has. like being cold-blooded.
That's exactly what it is. Cold-blooded animals are poikilothermic. Their body temperature just matches the ambient air temperature. Antipsychotics can disrupt the hypothalamus, which is our body's internal thermostat.
So if a patient on one of these drugs goes out into a summer heat wave,
They don't sweat properly. Their body can't cool itself down. They can overheat and get heat stroke.
and in the dead of winter,
They don't shiver effectively. They can't generate heat to stay warm. They can become hypothermic. This is a huge risk for elderly patients or for homeless patients who are exposed to the elements.
we have covered an immense, immense amount of ground. From the shrinking gray matter to the freezing basement, from the chemical lobotomy of the first-gen drugs to the black box of clozapine. Let's try to bring this all together in the outro and make sense of it all.
I think if I had to summarize the entire mission here, it's this. Schizophrenia is a profound biological event. It's not a choice. It involves the very structure of the brain, the chemistry dopamine, glutamate, serotonin, and the underlying genetics. And treating it is a lifetime of negotiation.
It really is a balance sheet, isn't it? Every decision is a trade-off. You are balancing the positive noise against the negative silence. You are balancing the mental relief against the physical cost, the tremors, the 50-pound weight gain, the diabetes, the immune risks.
And we are doing all of this with tools that are still, at the end of the day, pretty imperfect. They're blunt. We are, to use an old analogy, flooding the entire engine with oil just to fix one squeaky gear.
This leads me to a final thought that I've really been mulling over as we've talked. We talked about that Katie study, how the old drugs worked just as well as the new ones for the most part. And we've talked in excruciating detail about the side effects, the sedation, the flat effect, the weight gain, the tremors.
Metabolic tax, the movement tax.
Exactly. And the text mentions that the ultimate goal of treatment is not just symptom reduction, it's improving psychosocial functioning. It's about getting a life back.
Right. That's the whole point.
But I have to ask, if we sedate a patient enough to silence the voices, but in the process, they become obese, they develop diabetes, their hands shake so much they can't hold a coffee cup, and they lose all motivation to even leave the house, have we actually fixed them? Have we restored their life?
That is the haunting question of our field. It really is. We can fix the chart. We can make the hallucination score go from a 9 to a 2. But did we restore the person? Did we give them a life that they themselves feel is worth living?
It feels like we are saving the house from burning down, but ruining all the furniture in the process.
Until we have true precision medicine, until we can develop a drug that can delicately turn down the dopamine in the mesocaudate without touching the prefrontal cortex, or precisely modulate a glutamate receptor, we are going to be stuck with these hard, messy, impossible choices. The future has to be about specificity, finding the right key for the right lock, not just kicking down the whole door.
I think that's the perfect takeaway. Empathy. The next time you see someone who is struggling with this or hear about it, remember the biology and remember the incredible burden of the cure. It's heavy.
It is incredibly heavy.
That's it for this deep dive into the complex and challenging world of schizophrenia. Thanks so much for listening.
Stay curious.
We'll see you next time.